Good evening, everyone, and thanks for joining us tonight. Welcome to our webcast screening patients for refractive surgery using the OCULUS Pentacam. You'll see a text box on your GoToWebinar screen. Feel free to type in any questions as we go. We'll go through them at the end during our Q&A session. I'm excited to introduce tonight's speaker, Dr. Bill Tullo. Dr. Tullo is Chief Medical Officer at Oculus Inc. Before joining Oculus, he spent over 20 years as VP of Clinical Services at TLC Laser Eye Centers. He has maintained a private practice in his hometown of Princeton, New Jersey since 1988 and earned his Doctor of Optometry degree from the State University of New York College of Optometry. Dr. Tullo was assistant clinical professor at SUNY College of Optometry from 1988 to 1997. He is a fellow of the American Academy of Optometry since 1990 and a member of the American Optometric Association since 1984. In 2011, he was recognized by the American Academy of Optometry as a diplomate in cornea, contact lenses, and refractive technologies, the Academy's highest honor. Dr. Tullo, take it away.
Thank you, Michelle, and welcome everyone. Welcome to screening patients for refractive surgery using the OCULUS Pentacam. I'm going to give my usual disclosure to saying that these are solely my opinions and not the opinions of Oculus Inc. And let's get started. Most of you probably are familiar with the Pentacam if you're on this webinar. There are currently 4 models out in the field: the Pentacam Basic, the HR, the AXL, and the AXL Wave. Currently, though, we're only featuring 2 models, the Pentacam HR and the Pentacam AXL Wave, as we're trying to consolidate the multiple choice and options that are out there. But all the models, no matter what Pentacam you have, tonight's webinar is going to apply to that. We're talking today about refractive surgery in particular, and when it comes to the Pentacam, as you know, there are many, many displays to choose from. But for refractive surgery, the 2 displays we're going to focus on tonight are the 4MAPS refractive and the BAD, or Bell and Ambrosio enhanced ectasia display. When you look at elevation maps from a corneal tomographer, they look different from corneal maps from a placido disc topographer. So we're going to go through the differences on what to look for. But the first thing you need to recognize is when you're looking at a 2-dimensional piece of paper, a depiction of a cornea, it's helpful to know what's happening in reality in 3 dimensions. So when it comes to detecting keratoconus in particular, there are 2 things that we all agree upon. Number 1, we're looking for steepening and we're looking for thinning. So the question is, how do you get a cornea to steepen and thin at the same time? Well, you can thin a cornea by moving the front surface back, but you only flatten the cornea, you don't steepen it. You can move the front surface forward, but you don't change the curvature. What happens in real life is both surfaces are moving towards you, moving forward, but the back surface moves faster than the front. That's how you get the thinning and the steepening simultaneously. Now, when you look at elevation maps, again, you're not looking at the raw data. You're looking at the raw data plotted against a reference shape. And we're going to talk about reference shapes in a few minutes, but I prefer to use a sphere as the reference shape because what I'm looking for is I'm looking for abnormalities or astigmatic toric abnormalities. If I use a toric surface or an aspheric surface, to me, visually, it hides early abnormalities. If I use a spherical surface, those early abnormalities visually will pop out and I'll be able to see them a lot easier. So I'm going to talk tonight using only spherical reference surface shapes. But here's the 3 basic things that you look at when you look at elevation maps. On a spherical cornea with a spherical a reference shape, a spherical cornea is going to look very uneventful. It's going to be very uniform, typically green from edge to edge, and there will be not a lot to see on a spherical cornea, and that's how you tell if you have a normal spherical cornea. If you have a normal astigmatic cornea with orthogonal normal astigmatism, instead of the classic bow tie that you see in placido topography, you're going to see this classic saddle shape as you see here in this example. And with normal astigmatism, the saddle shape is going to be symmetrical top to bottom and left to right. What we're looking for abnormalities, particularly in keratoconus, is we're looking for islands of elevation. And as you see here in this example, this patient with early keratoconus has a significant area of elevation. And again, remember the colors, the warmer colors, the yellow, orange, and reds are moving towards you, and the blues, the greens, the blues, and the dark blues, purples are moving away from you. So warm is towards you, cool is away from you. And you need to think about this in 3 dimensions. Now, like with a visual field, you need to make sure you have a reliable exam with no fixation errors. The same thing is true with a reliable tomography from a Pentacam. And there are 4 steps your technician should do on every single capture of a Pentacam. Number one, they're going to check the shine fluke images and making sure the room environment is proper. We'll talk about what that means. Make sure they get a white to white, a horizontal white to white measurement, which means we have a visible iris, and we'll show you what that means. You need to have normal quality specifications or QS score, and you need to have scan coverage of a full 8 millimeter scan coverage. So let's go through what that looks like. On your initial display, you're going to see the 25 shine fluke images, and what you're looking for here are 2 things. Number one, you can see a little bit of upper lid covering on the first 3 or so images here. Ideally, you'd want to see a fully open eye all the way through. But again, you just want to glance at all 25 images and make sure there are no major obstructions that are blocking the shine fluke image. You also want to take a peek down below at the iris image and make sure you can see all, if not most, of the iris and the lids that are not in the way. As far as the room environment goes, the Pentacam should always be in a dark room. And any external light can really reduce your edge detection and reduce the quality of your scans. If you can't get the room dark enough, I'd recommend using a drape over the patient so that no stray light gets into the Pentacam camera as it's capturing its images. So that's really important. Here's an example of what a good shine fluke image should look like. You should see a nice dark background, and a bad one with the lights on in the room here, you can actually see the reflection of the iris, the sclera, and the eyelids. So again, this highlights too much light in the room. And here's just a side-by-side good scan next to a bad scan. So again, lights must be off. The only light should be the monitor, which actually will turn off as the machine starts to rotate. Number two, again, you need a horizontal white to white. The reason you need that is you need to make sure you have good coverage. Again, you can look at your iris image in the upper left corner of the general overview display, but you can also look at the capture of the actual horizontal white to white, as we see down here, down below. If this image is blocked by the lids or by eye movement, you're going to see a blank entry here. There'll be no number. So once you see that you have a horizontal white to white measurement, you can be assured then that you have a pretty good scan from the aspect of capture size. Quality specifications, well, there's a lot of things that can cause problems with quality specifications, including blinking, including movement, including alignment, or patients sometimes will pull their forehead away from the plastic band they should be up against. So what will happen if you look at the general overview display and you take a look at the QS value? The QS value here you can see is white and okay. You can actually click on this QS value, especially when it's yellow and red, to find out what exactly is going on. When you click on this value, this box will open up and you'll see 5 different analyses of the front of the cornea. You'll see 5 different of the back. And you see in this patient, even though the QS was white, they did have a little bit of 3D model deviation on the back of the cornea. And that will reduce the edge detection slightly and make your scan not ideal, but because it was so minor, this qualified as a passing QS score. But it's always good to know if there's an alignment issue, eye movement issue, and this QS score is always good for your technicians to understand and to click on so they know how to remedy this, because they're going to need to repeat this. If the QS score isn't white, they should go back and repeat that measurement. And the last thing is scan coverage, and we want to get at least 8 millimeter scan coverage on all eyes. Depending on your default settings on your Pentacam, lost data will either be represented by this white plain box here or black dots as you see here. And this is all extrapolated data. When you see the black dots, even though there's blue and purple colors here, you need to be cautious of this data because extrapolated data is never as good as actual captured data. So whenever you see missing data, especially of this extent, where you see here about 4 millimeters of coverage, that's really not sufficient, especially not sufficient in a refractive surgery screening process. All right. Now, and basically, when you look at the live image, what you see is what you get. So if you got upper lid covering the cornea, either superiorly, inferiorly, you're going to lose data. So it's important to have patients open their eyes wide as possible, and even sometimes help them open their eyes using either a lid stick or a Q-tip or some other way that you're not pressing on the globe. So once you've got good maps, and this is something your technicians should never hand you, is an example of a map with a QS score in the front of the cornea and the back of the cornea that is red. And what this means is the edge detection is very poor, and that these results cannot be relied upon. So you notice on this is a 4-map refractive. And on a 4-map refractive, you have 2 QS scores, not one. And you'll notice on a lot of the Pentacam displays, each display will have their own special QS value. And as we'll go through this, we'll show you that you can actually have normal QS on one display and abnormal on another, because the QS value is specific for the display and what the display is trying to depict. So technicians should know to look at these two things before they either print or send these images to your EMR, because this would require a recapture. Now, what are you looking at? Remember I said you're not looking at raw data, you're looking at raw data placed upon a reference surface. And the reference surface in most cases, and in the cases tonight, we're going to talk about is a reference sphere. And the best fit sphere, the reason we choose that again is because it highlights those very early irregularities typically found in keratoconus. If I would switch these very early keratoconus cases to a best fit A sphere or a best fit toric A sphere, you would notice visually, while the numbers won't change, visually it'll become much more difficult to discern those early islands of elevation. So again, best fit sphere is my choice. As far as color scales go, when I'm screening patients, I always use the Bell Intuitive color scale, especially for my elevation maps, my back and front elevation maps. But I do occasionally switch to the American color scheme when I'm trying to diagnose a specific problem. So for screening, again, Bell Intuitive color, and for more detailed analysis, I may switch sometimes to American color, but that's only if I see something in the intuitive color scheme that I'm not comfortable with and that I need further explanations. And the reason I find the intuitive color scheme very, very effective is when you're screening patients visually, you want to see those islands. If you look at this example, I can tell there's a 12 micron island here very easily. When I look at this map in the American color scheme, the island is not visually impressive to me at all, and I have to really analyze this a lot more carefully. So again, what the intuitive color scheme does, it turns everything that's normal green and everything that's outside of normal range a different color, typically yellow, orange, or red. Let's take a look. I'll bring you through the algorithm that I use when I look at the maps. Again, when someone sends me a consult request, I always ask for the U12 files, which is the export from the Pentacam. It allows me to manipulate the files, but more importantly, I always need to be able to get the maps that I want. I always want, with refractive surgery, the 4-map refractive and the BAD Bell and Ambrosio display. So let's go through what we look for in the 4-map refractives. And remember, the 4-map refractives are the front and back elevation maps, the axial sagittal curvature map, and the corneal thickness map. So the first thing I look at always is the elevation maps. And what I do is I look first for any islands of elevation. This is an example of a normal eye, so we don't see any islands of elevation. The next thing I do is I visually split the maps in half, left to right, and I want to see symmetry. I want to see the left side and the right side are mirror images of each other. As you can see in these examples on the front and the back, these are almost perfect mirror images. And then I do the same thing horizontally, comparing top and bottom. Again, I want to see symmetry. In normal eyes, symmetry should prevail. Now, this is a really nice example of a normal eye. And as you know, not every normal eye is going to be quite as perfect as this. So there is a continuum, and we'll show you some examples of that later. So again, just to repeat, look for islands, compare symmetry left to right and top to bottom. Then I move to the left two maps and the axial sagittal map. I do a lot of the same thing on the axial sagittal maps as I do on the elevation maps. I look for symmetry left to right. I look for symmetry top to bottom. Then I also look for a skew of the radial axis. And what that means is means that I'm looking for non-orthogonal astigmatism that is not 90 degrees away. The easiest way to look at that is you see these red segments here, they almost line up perfectly, which means the astigmatism as we go from the vertex normal out to the periphery is almost perfect and uniform and orthogonal. So this is an example of very nice orthogonal astigmatism with virtually no skew of the radial axis. And we'll show you some examples of abnormal eyes later on. And the last thing I look at is the corneal thickness map. And my eye goes immediately first to this hollow circle. The hollow circle is the thinnest point of the cornea. And the reason it goes there is because if I'm looking for keratoconus or ectatic diseases are always going to be centered on the thinnest point. And with keratoconus in particular, since it's a regional disease of the cornea, typically 4 millimeters or so of the cornea, I'm going to look visually on that 4 millimeters around the thinnest point. I'm going to look to see where the thinnest point is. The thinnest point should be close to the vertex normal, which is at the line of sight, and it should be about 0.8 millimeters or less away from that. We know keratoconus can be in any direction, but with the thinnest point, most cases of keratoconus, the thinnest point will decenter in the inferior temporal direction. But it doesn't mean you can't have keratoconus in any other direction. I have seen many cases of superior and nasal keratoconus also. But again, you want to look at the magnitude of this decentration, especially if you have serial maps over time. If that magnitude is going further and further, that's a warning sign also. So the other thing I look at, though, besides the decentration, if you look at the colored circles here, these concentric circles as we go out to the periphery, these should be fairly circular, if not just maybe a little bit oval, and they shouldn't take on odd trapezoidal or tetrafoil-like shapes. And we'll show you some examples where these circles of increased thickness of the cornea are no longer radially uniform. So with keratoconus, if that's one of the conditions you're looking for, and certainly in refractive surgery, we don't want to be doing surgery on eyes with keratoconus. To make that diagnosis on the 4-map refractive, you need to have 3 different conditions. Number 1, you need to have abnormal elevation on the back of the cornea. And that we know the cutoff is 18 microns. The machine will tell you this, so you don't have to memorize the numbers I'm telling you. And you have to have abnormal elevation on the front of the cornea, which is above 8 microns. And these areas of elevation on the front and back need to be geographically in the same location. The back elevation needs to be greater than the front. And the last thing, the thinnest point, the hollow circle, has to be in the region of the elevation. In this example here, we see those 3 characteristics are fulfilled. If this thinnest point was all the way on the nasal side, yet you had elevation on the front and back that was in the same location, that's an abnormality, but it's not necessarily keratoconus because, again, keratoconus is around the thinnest point. It doesn't mean you have a normal cornea. It just means that your abnormality may be something other than keratoconus. And the last thing I want to mention is because keratoconus is a disease of asymmetry, not only within an eye, but between fellow eyes. One of the things that you manually have to do when you're screening patients for refractive surgery is compare the right and left eyes. Every day I get emails from people asking me my opinion on cases, and at least once or twice a month I'll get a case where they'll send me just a right eye or just a left eye, and I always email back and say I can't make any determinations looking at one eye only. I need to see both eyes for several reasons, but one of the reasons is I want to look at the thinnest point in right and left. I want to subtract it, and we know that asymmetries in thinnest points of 17 microns is suspicious and 25 microns is abnormal. So it's an important criteria that I do need to accomplish manually by doing that mathematics. Let's walk through some obvious cases. Let's start off with a normal cornea here, and we'll see here on the elevation, which I look at first, top to bottom is symmetric, left to right is symmetric, and there are no islands of elevation. Back elevation, again, left to right is symmetric, top to bottom is symmetric, and again, no islands of elevation. So I would call the elevation maps both normal. When we look at the axial sagittal map, you have a beautiful symmetrical bow tie. Again, top to bottom symmetrical, left to right symmetrical, and there's virtually no skew of the radial axis again. So I would call this map normal. And we go down to the pachymetry, the corneal thickness map. And again, we look first at that thinnest point, and I can go over to see that the thinnest point is 0.67 millimeters decentered in the x direction and zero point 0.4 in the y direction. And when I look for in the x direction, if I get more than 0.8, and especially when I get to 1 millimeter, that's when I start to worry that this is not a normal eye. So this is certainly within normal criteria, and you can see the concentric circles are pretty circular and uniform. So I would call all four of these maps normal when I look at this cornea. Now, if you look at this cornea, this is an early case of keratoconus. When I do the same criteria on the front elevation here, top to bottom, left to right is symmetrical, top to bottom is symmetrical, and I don't see any islands of elevation. So the front elevation is normal. But when I get to the back elevation, immediately I see with this color scheme, I can see this island of elevation. And if you remember, I said 18 microns is normal or less, and this is 27 microns, and we can see this very distinct posterior elevation island. So I would call this abnormal. If I look at the sagittal map, I start to look at the bow tie here, and I can see that I have some inferior steepening. If I look at the 45.9 inferiorly here compared to the 45.3 here, it's only about a half diopter difference, but it certainly looks like the top of this bow tie is not the same as the bottom of this bow tie. But more importantly, take a look at the skew of the axis here. This is about a 15 to 20 degree skew, and that certainly is insidious, and I would call this a fail and an abnormal. And I go to the corneal thickness map. The thinnest point is pretty close to the vertex normal. In fact, if you look here, it's 0.5 millimeters, but the cornea is pretty thin. The thinnest point here is, again, below 500 microns, 489. So I would call this a fail. And so I have a fail in the back elevation, a fail on the corneal thickness map. And as I'll show you later on, whenever we get a fail, we need to take a good look at the BAD map to use our normative data just to make sure that this is truly a abnormal cornea. Let's take a look, though, at a more advanced case of keratoconus. And here's a case that's much more obvious and much easier to see. When we look at the front elevation, we compare left to right, we fail. It is not symmetric. We compare top to bottom, we fail again, it's not symmetric. And we see this obvious island that's greater than 8 microns, 22 microns on the front. And when we go to the back, we have the same failure left to right and top to bottom. And the island in the back is greater than the island on the front. It's 54 microns, and it's in the same location. And if you look very carefully, unfortunately, the numbers are covering it, but your thinnest point circle is right here, and it's right in the area. So we have the three criteria we talked about. So even without looking at the other two maps, I would say this patient fails and fails, and this is likely keratoconus. If we look at this axial sagittal map, again, we see the bottom lobe here is 52 diopters and the top lobe is 45. That's 6.5 diopters of asymmetry or IS ratio. That certainly fails the Rabinowitz criteria of 1.8 diopter difference. And we also see here again the skew in the radial axis. So this would be a fail also. And then we go down to the corneal thickness map and we immediately see also the thinnest point is fairly decentered. Doesn't hit the 0.8 microns, but it's 0.6 in both directions. But the cornea is very thin, 410 microns. Now, a thin cornea all by itself is not a positive predictive value for keratoconus, but when you combine a cornea this thin with a cornea with elevation like this eye has keratoconus till proven otherwise. And here again is just another advanced case. See 22 microns on the front here, island. It'll fail the left to right and the top to bottom. On the back, again, fails left to right and top to bottom, and we see 54 microns here. Another case of advanced keratoconus with, again, an asymmetry of about 7 diopters here and a skewed radial axis and a thin cornea. So, again, these advanced cases are much easier to make the diagnosis, and these are not the ones that typically get sent to me in the mail. It's always the more subtle ones. So that's the 4-map refractive, and I think the 4-map refractive is still very useful, but the most useful tool for me in refractive surgery patient screening is the Bell and Ambrosio display. And currently we are featuring version 3 of this display. I'm going to talk to you at the end of this presentation about version 4, which is going to be coming out later this year. But with version 3, what this utilizes is it utilizes a normative database of normal eyes and abnormal eyes, so you can compare your patient and your patient's eyes to these normalized database, and it gives you a regression analysis using, as we'll see, 9 different variables to give you a predictive normalcy value and standard deviation, which is what's called a final D value. But we'll talk more about this in detail. So remember, we talked about the quality score specifications on the 4-map refractive. We had 2 of them, but on the BAD map, we have 1 single quality score. As you can see here, it's highlighted in white, so that's a good thing. And this quality score is different from the quality score on the 4-map refractives. So your technicians need to look at this to make sure, because just because your 4-map refractive was white, it doesn't mean that your BAD will be white, because the criteria for normal on these 2 displays is very different from each other. In addition, on the BAD display, you also need to look at not just the QS score, but you need to look at the capture diameter. Again, because a normative database includes eyes only with 8 millimeters or more captured diameter, if you capture your patient at a diameter less than 8 millimeters, you can no longer rely on the final D analysis. As you see in this example, the final D is abnormal, 3.65, it's red, but this patient was captured at way less than 8 millimeters on both the front of the cornea and the back, and you see it lights up red. And the reason for that, you can see all this extrapolated data from the upper lid. Again, this scan cannot be relied upon. This is like a visual field with a fixation loss of 8 out of 8. You can't rely on that result. And it's the same thing when we look at tomography. We need to get not just a good quality score, but we need to also get a good 8 millimeter capture in size. So this map to me is not useful at all. If you look at the QS score, it actually tells you this patient was blinking, and you can click on this like we did before, and you can get the details of exactly. But for your technicians' purposes, they just know that they didn't get 8 millimeters, and they just need to go back and repeat that before they hand you this information and data. So let's talk about the BAD, and let's start talking a little bit about the left side of the BAD display. The left side of the display highlights changes in elevation, and we're going to show you a little trick that was developed by Michael Bellin called the Bellin-Ambrosio Enhanced Ectasia Map. So in the normal eye, the best fit sphere, which is the reference shape that the data is plotted against, uses all 8 millimeters of data and averages it, produces the best fit sphere, and then puts the actual data on the best fit sphere. And you can see in this eye, there's some data is above the sphere, some data is below the sphere. But what we do with the enhanced ectasia display is we actually eliminate the pathological data, if there is pathology, of about 3 to 4 millimeters around the thinnest point, which is typically the steep data of the abnormal part of the eye, and we recalculate the best fit sphere, which will be flatter and resemble the normal parts of the cornea. And what that does visually for us, it makes the prominent nipple of the cone much more easy to see. So what we see again in eyes with keratoconus, that area steepening causes that steepening in the best fit sphere, but that steepening in the best fit sphere visually makes the nipple of the cone much less distinguishable. So this enhanced ectasia will highlight it. And in a normal eye, the enhanced ectasia doesn't change because there is no steep area. There is no abnormal area. So the best fit sphere will be the same before and after you exclude that data 3 to 4 millimeters around the thinnest point. And here's just an example of where the data would be excluded right here around the thinnest point. All the rest of the data would still be used to calculate that best fit sphere. And here's a real life example of how it looks in a normal eye and in an abnormal eye. On the top, we have an eye here that's normal, and this is the normal elevation, front elevation map. And then to the right is the enhanced front elevation map. And if you look at the two visually, they're very, very similar. There's not a big difference between them, and that's true in normal eyes. But in pathologic eyes, even early pathology, you see here the normal elevation map, and then you see here it replotted with the new best fit sphere. Look how much easier it is to see that elevation area. And so visually, it's just much, much easier. So that's what that left side of the BAD display shows us. The right side of the display is more about how the cornea thickens from its thinnest point out to the limbus. And we call that pachymetric progression. And it's just the way the volume of the cornea is distributed throughout the cornea. And we know most people's thinnest points is somewhere near the center or near the vertex normal of the cornea. And you see here in the CTSP map, the red line is a graph of your patient's cornea, how it thickens from the thinnest point on the left and how it thickens as it goes out all the way to the limbus. Now, the red line is your patient, but the black lines are standard deviation of normal eyes. So this gives you not just a standard deviation, but it also gives you how the shape of the curve should be. And you notice in this example, the red line is following things perfectly till about here, and now starts to droop down below because it's actually thickening at a faster rate. And the PTI graph does essentially the same thing. The only difference is instead of using the actual pachymetric numbers that's averaged over the 25 slices, it actually will use a percentage of increase. And I like the PTI map better than the CTSP. So visually, my eyes go right to the PTI map. I look at the red line and I look for the red line to go anywhere outside of the confidence interval. And you can see on this example, boy, it goes right to the edge and maybe just below it out here in the 6 to 7 millimeter area. So this is concerning to me because, again, I can see this negative slope. And in ectasia eyes of all kinds, any type of ectasia, you're going to see this negative slope start to increase. So here's an example of severe keratoconus. You can see the patient started out with a 250 micron cornea, and it thickened very rapidly. You see a big negative slope here, and on the PTI graph, the graph is totally outside the normal confidence intervals, and this is very easy. But this is an eye that's very easy to diagnose. If we look at a more moderate case, well, now we still see this very negative slope in the moderate case. The stippling of these lines usually reflects the fact that this patient has a thinnest point that's very far decentered. And as you can see in this patient here, the thinnest point is more than 2 millimeters away from vertex normal. So what that means is when the Pentacam shine fluke camera is scanning in a circle, when it gets, and it's scanning around the thinnest point, when it gets to here, you start to lose data because you can't get data all the way out here. And that's what the stipple line means, is that you have incomplete data in some of the segments as the camera spins around. The solid line means you have data in all 25 segments. But nevertheless, this negative slope is indicative of keratoconus, and you can see in the PTI very obvious. And this is just a moderate case. When you look at mild cases, it becomes a little more challenging. You have to look a little bit more carefully. And again, my eyes for the slope will typically go between 4 and 8 millimeters. And I'm looking at the slope of the red line compared to the slope of the black lines. And you can see here, there's definitely a negative characteristic to this slope. And with the PTI, it's even easier because you can see this red line goes down outside of the black confidence interval. So pretty easy to see even in mild cases. And you can also have other corneal abnormalities that are easily diagnosed with this. A patient with Fuchs dystrophy, what happens is as the endothelial dysfunction occurs, your central corneal thickness gets greater, which means that the center of the cornea starts to resemble the periphery of the cornea, and you actually get flattening instead of drooping. You get a red line that's actually flattening. And again, this is characteristic of Fuchs, where the red line is going to go outside the confidence interval on top, not on the bottom. So this is the Bell and Ambrosio display, and just the way I look at this map is my eye immediately first goes to the final D measurement. Why is that? Well, there's a lot of numbers on this display, but the only one that has positive predictive value in a refractive surgery setting is the final D. So the final D number is the most important. Now, I will look at a lot of other numbers to try to explain a final D. So if my final D is yellow or red, I want to know why, and these are the numbers will help you. We'll show you examples of that. But I start off looking at the final D, I look at the color and I look at the number, and then I will switch my eyes, and I'll switch my eyes over to the left side and look at the elevation. Now remember, if you look at the 4-map refractive, 3 of the 4 maps from the 4-map refractive are on the BAD display. The front elevation you see here is exactly the same as the front elevation map on the 4-map refractive. The back elevation here is the same as the 4-map, and the corneal thickness is the same as the 4-map. So you've got 3 out of the 4 maps that you saw on the 4-map refractive, but now we're looking at them in a different way. So when I look at this front elevation map, the next thing I want to do is I want to go down one step and look at the enhanced elevation map. And I want to see, is that enhanced elevation map different than the unenhanced map, the top one? And the best way to do that is look down at the third map, which is just a difference map between the subtraction of the normal map and the enhanced map from each other. And we color coded this to make it really easy visually. So if it's all green, it's normal. If it's yellow, it's suspicious, and red, abnormal. Then I do the same thing for the back of the cornea. Look at the elevation, the unaltered map, look at the enhanced map, look to see, I don't see any visual difference, but I also see the difference map here is all green. So that's making me feel good. We have a final D that's white. We have both back and front elevation that's green. And then the last thing I'll look at, and I like to look right to the PTI map, I'm going to look to see that my red line is the same shape and within those confidence intervals, and it is here. So all these things make me feel very comfortable. The last thing I look back is I start with the final D and I end with the final D. And again, this is when I look at the 4-map, then I look at this, I can say that this is normal, but I need to see the left eye also, because this could be the better eye of an eye with a patient with keratoconus. So I never want to look at just one eye only. The other important thing on patients who are not myopic, the BAD display was designed for refractive surgery, and by far 90+% of patients we do refractive surgery on are myopes. So the default database on the BAD is always myopia. But there are times where we're screening patients who are emetropic or hyperopic or mixed astigmatism. And when that's the case, we have to change databases manually. Here's an example of a hyperopic patient who is being screened for refractive surgery. And look at here, the final D is screening yellow or suspicious. When I look at the map, I look here, I see nothing on the front, but on the back, I do see this little area of concern, but my PTI graph looks totally normal. So is this indeed a abnormal suspicious eye? But look, they used a myopic database on a hyperopic eye. When I switch the databases, look at that, the final D becomes white and normal. So again, the correct database must be used. And again, the default is always the myopic database, but you have to, your technicians need to know what's the refractive status of the patient you're screening. So as a summary, the BAD or the BAD3 map is designed for early detection of abnormal corneas, not just keratoconus, but abnormal corneas, including ectasias, and is very useful for screening patients for refractive surgery. And again, the colors on the final D will light up yellow when you get to 1.6, and then when you achieve 3.0, it's going to turn red. Now the colors on the sub D values, the cutoffs are a little bit different, but on the final D, which is really the only one that I'm going to look at to make a determination, I'm not going to use the sub D values to determine, because as we'll see in examples, you can have yellow and red sub D values in white normal corneas. And the reason for that is those individual parameters, the 9 individual parameters that go into the final D regression analysis, none of them have positive predictive value high enough to use them alone. And the easiest example I can get you to understand is we see plenty of eyes that are below 500 microns in thickness, even as low as 450 or lower, that are normal eyes. And we also see eyes with keratoconus that are 550 and above. So that parameter is not a predictive parameter by itself. In coordination with the other 8, it's very, very helpful, which is why we really have to use the final D to make our determination and not the sub D values. And also the research has shown that that final D value has the highest sensitivity and specificity of any other parameter, including artmax, which we'll talk about later. The other important thing, and I see this almost every week, people sending me maps of eyes. Once you do any surgery or alter the cornea at all, the Bell and Ambrosio display does not have a normative database for eyes that have had LASIK, eyes that have had any corneal altering procedure, including RK or even cataract incisions. Once you alter a cornea, the BAD map display cannot be used. So again, just to summarize, that final D is a regression analysis of 9 parameters. Now, people always think it's 5 parameters because you only see 5 sub-D values, but there are really 9 sub-D values, 4 of which you just can't see. They are the least important or the lightest weighted ones. The 5 you see here are the heaviest weighted parameters in the final D, but there are 9 parameters in the current BAD3 display. And this is the ROC curve. The ROC curve shows you the sensitivity and specificity of a test. And there are a lot of tests in medicine that have sensitivity and specificities in the 70 and 80 percentile, considered excellent tests. Well, the BAD3 has a sensitivity of 94% and a specificity of 94%, which is considered in healthcare an outstanding test. But it also means it's not 100% sensitive and specific, and almost no test is. So that also means that there's a risk of 6% of false positive and false negatives. And that's why I always train every doctor I work with is that this test is extremely important for screening patients, but it's not the only thing. We'll talk about other things that you have to consider in addition to tomography. In refractive surgery screening, we always want to balance the sensitivity and specificity, but in reality, we really want no false negatives. Why? Well, we don't want to do surgery on a patient that has corneal disease, particularly keratoconus, because the likelihood of making that patient progress goes up significantly whenever you alter the cornea with a blade or a laser or anything. So we really want no false negatives. But the predictive value of the test really depends on the cutoff you choose. And just here's an example. If your final D cutoff for doing surgery or not doing surgery or doing LASIK and not PRK is 1.65, you have to know that you're going to accept 5% of those patients will be false positives, and you're going to turn them away when they actually were good candidates. If you go up to 1.88, well, the false positives decrease significantly by 50%, down to 2.5%. And obviously, the higher cutoff you have, the less false positives you have, but also the less surgery you will perform. I can never get through this lecture without someone asking me the questions, what are my personal guidelines? And my personal guidelines were based on my 20 years of experience at TLC Laser Eye Centers and also working with people like Michael Bellin. So for LASIK and SMILE, I use the same cutoffs, and it's very age dependent. As we know, corneas are much easier to destabilize the younger they are because of the natural cross-linking that does occur with age. So my cutoffs go up as the age goes up. For young patients under 30, my LASIK SMILE cutoff is 1.6. As they get a little bit older, it goes to 1.8 up to 2. And then for patients over 40, my cutoff would be 2.2. And this is based on a combination of statistical risk of corneal ectasia and just my personal experience dealing with hundreds of patients that have had corneal ectasia after LASIK. My PRK final D cutoffs are a little bit different. You'll notice that the cutoffs are about 0.2 higher in each category for PRK because in general, PRK is less destabilizing than LASIK and SMILE. And now I mentioned additional factors besides tomography. Well, I'm always going to look for historical astigmatism change over time or asymmetric astigmatism between right and left eye. Ideally, that's corneal astigmatism, but it also sometimes could be just looking at the refractive error or the glasses over years gone by. So I always ask patients when I don't have perfectly clean examinations, can you get me some of your old records so I can review them? I can review the refractions and the spectacles and look at the astigmatism. The other thing we learned, unfortunately, was that best corrected vision is very important, and symmetrical best corrected vision is very important. And we learned in one of the papers that we presented at a ACOS meeting about 15 years ago was as little as 3 letters of asymmetry in best corrected vision between eyes is a risk factor for developing post-LASIK ectasia. So we want to refract our patients very carefully. We also want to push them beyond 20/20 because we also saw that patients who can achieve 20/15 in one eye, 20/20 in the other, that's 5-letter difference, and that is important. And I know most people, when they refract patients in a general optometry setting may not push patients beyond 20/20, but I would encourage people in the refractive setting to really push your patients to their best vision, whatever that number is, and then look for asymmetry. And asymmetric vision is not only an indication of ectasia, which also can be something as simple as dry eye. But nevertheless, whenever I see three-letter difference, I want to explain what's going on. I also want to look at vertical coma. We also know that asymmetric vertical coma, or any coma above 0.3 microns at a 6 millimeter capture, is also clinically significant. And the other additional factors is asking about family history, if they have any keratoconus. Now, patients often don't know the word keratoconus, so I'll ask my patients, does anyone in your family, do you know, wear hard lenses? And that sometimes is a good substitute for asking about the word keratoconus. I also ask about eye rubbing, also ask their significant other if they rub their eyes. And I can now always ask the patient, show me how you rub your eyes, because patients with keratoconus have a higher tendency of rubbing with their palm or their fist versus their fingertips. Get atopy history. Again, frequent changes, unilateral refractive changes. And the other one that I picked up on is it's that toric soft lens wearer where you fit them in one eye in one try. It's perfect 20/20. And then in the other eye, the fellow eye, you're on your third or fourth lens and you can't get the axis right. You can't get the power right. That patient should get a tomography because there's a good chance that they may have non-orthogonal astigmatism and possibly even ectasia. And also, while we don't have a commercially available genetic test anymore, in the future, I'm sure we will, and genetic risk factors, since we know keratoconus is a genetic disease. Probably one of the most misunderstood things by patients is a lot of patients would say, well, I only have keratoconus in my right eye. And we all know that keratoconus is not a single eye disease. It's a corneal disease. If you have it in one, you have it in the other, even if you don't show any signs upon clinical examination. Now, the other question I get quite often is, okay, I'm screening my patients for refractive surgery. I get a suspicious map. What should I do? Well, the answer is disease gets worse over time. Normal corneas stay the same. So surveil your patients. And how often do you surveil them? Well, when I'm in my clinic and I'm seeing young patients, especially under 20, I'm going to have that patient back if they have an abnormal scan. I'm going to have them back in 6 to 8 weeks. And the reason for that is the younger the patient, the quicker they're going to progress. And particularly with young patients, 10-year-olds and 12-year-olds, those patients could progress very quickly. And if you have them back in a year or 6 months, you very much can find multiple lines of loss of vision in these very young patients. So if you're using this technology to screen young patients, especially one that's too young for refractive surgery, and you find a suspicious map, you want to surveil them pretty closely. And I would have them back in 6 to 8 weeks. And I would repeat that in the first year multiple times. If they're older, between 20 and 29, a suspicious map, I'd have them back in 3 months. Between 30 and 39, 6 months. If they're older than 40, a suspicious map probably won't change very quickly. So I'm going to wait a year and have that patient back in a year to determine whether there is truly any change. It's really a matter of establishing stability because we don't want to operate on any eye that's abnormal or unstable. A variant ectasia that is a variant of keratoconus, in my opinion, is pellucid's marginal degeneration. It's just a type of ectasia that is specifically located 1 to 2 millimeters from the inferior limbus. Most experts, like I, feel that this is just keratoconus in a very specific location. Nevertheless, because it's so close to the limbus, this is something that can be missed if you don't look for it. One of the characteristic telltale signs on the axial sagittal map is those kissing doves or the crab claw effect. But the real diagnosis of pellucids is if you accept the definition of thinning 1 to 2 millimeters from the inferior limbus, you need to look at the inferior limbus and the corneal thickness in that area. And with the Pentacam map, you need to open it up to 12 millimeters. The default setting on most Pentacams is going to be at 9 millimeters. So you're only going to see the 8 millimeter cutoff here if you don't open it up. And so when you open up the map, and this is how you do it, if you've never done this before, you go into your map, you left click on the map, And this is going to come up, and you want to uncheck max diameter at 9 millimeters. So again, go to your corneal thickness map, left click, this box will open. You uncheck this box and it will open up to the full 12 millimeters. And then you can really see where the thinning is. And here you can see two examples of classic thinning right at the limbus. And this would be a case of pellucids. In fact, probably 80% of the cases of pellucids that get sent to me are really just by definition inferior keratoconus because they're not that close to the limbus, but they're treated in exactly the same fashion. Now, I want to close with another important topic, and that is a question I get asked all the time. Well, if the BAD map can't be used once an eye has had surgery, how do you detect post LASIK, post PRK, post SMILE ectasia? Well, let's talk about how you do that. Number one, we can't look at the anterior surface or the pachymetry map because those have been surgically altered. So we have to focus our attention on the back of the cornea, the part that wasn't altered. So looking at the posterior surface, the best case scenario is that you have maps before surgery and maps after surgery. And then you take what's called a compare to display, and you take the map um, after surgery and subtract it from the map before surgery and get that difference map. And that difference map will tell you if there are signs of weakness or abnormal elevation that have changed since the surgery, because the back of the cornea should not change after a refractive surgery procedure in a normal eye. So this is an example of a compare to map before and after surgery, and the difference map here has no areas of elevation. This is another example of an eye that has of LASIK ectasia, and you see here before surgery, after surgery, and the difference map here shows you this obvious island here. And again, 6 microns for me is suspicious, 16 is abnormal. In this eye, we have 25 microns of elevation here when we do the difference map. It is very important that this difference map is done properly, though. And when I say properly, the best fit sphere before and after surgery is often going to be different. In order to do this accurately, you need to make the best fit spheres match. The way you do that is, I'm going to show you right now, is again, you take your compare to maps, and before you calculate it, you go onto the best fit sphere and you look at which one is the flatter best fit sphere. And then you click on it, right click on it, and when you right click on it, this will appear, and it says change reference shapes. If you go down to the box that says change reference shapes and click it, what happens then is the best fit spheres will match. And when they match, then you can look at the map and determine whether you see 29 microns here of elevation. That's clearly not normal. But it's really important that you make your analysis with matching best fit spheres. Whether you use the flat or the steep is really not as important as making sure they match each other. And sometimes the difference can be a lot more than just the 0.4 millimeters as you see here. And this is just an example of a post-LASIK eye. Another great use for the Pentacam is here's a patient that came back after LASIK surgery, 49-year-old female. Everything looked great on their 1 week and their 1 month post-op, and now they're complaining of glare at night. Whenever I have a post-LASIK patient comparing a glare at night, one of the first things I want to figure out is this glare due to the application of the laser? Was the laser centered properly on the eye? The best way to determine the centration of an ablation is not to look at a front elevation map after surgery, but to look at a difference map, meaning taking the pre-surgery map, the post-surgery map, subtracting them, and again, making sure the best fit spheres match. And then you can see beautifully exactly where the ablation is in regards to the pupil. And so now I can determine, no, this is not a discentered ablation, which maybe in this map you might think it was. And sometimes the post-op maps can look very discentered, but then when you look at the pre-op map, the optical apex was also discentered then also. So the difference map is really, like compare to map is really the map you need to make that determination. And you can also use a compare to map to see if you took away enough tissue. It's not unusual sometimes that a patient will come back in a 3-month visit, and while they were -6 to begin with, now they're -1 and they're not plano. And you're like, well, what's going on here? Did the laser take off the right amount of tissue? We know the laser prints out the ablation depth, but they're not always very accurate. Again, there's humidity, there's temperature issues. But in any case, you can find out exactly how much tissue was taken away. You take the corneal thickness map here before surgery, subtract it from the after surgery, and the compare to map will tell you, look, 90 microns. That tells me, because I know my laser takes out 15 microns per diopter, that this 6 diopters was truly removed on this patient. So this was not a laser problem. This is probably more likely either a dry eye problem or some other regression related problem. Also, I talked about vertical coma. Where do you find that on the Pentacam? Well, depending on the version of your software, older versions of software have a display called the Zernike analysis, but newer versions will have the same display renamed as the aberrometry cornea. And again, if we look down to coma 90, which is the one that's most sensitive for ectasia, we can see in this particular patient here that we have 0.38 microns of coma. That's a lot. You can also see here when you use the normalized view, which is the view I tend to like versus the pyramid or the list, the normalized view will give you standard deviations of normal. And the white is normal, gray is suspicious, and the darker gray is abnormal. And you can see the vertical coma here is in the suspicious area. So the aberrometry cornea display in the Pentacam can be also very helpful when you need tiebreakers to decide exactly whether your cornea is normal or abnormal. And I want to close with what's coming soon. I'm very excited to announce that later this year, BAD4 will be available. BAD4 will have a regression analysis. It'll look a lot like BAD3, but instead of using 9 variables, it's going to use 12 variables. And the advantage of that is the sensitivity and specificity is going to go from 94% to 97%. So another great improvement in the software. In the future, we're also going to have normative values for things like chord mu, chord alpha, coma, spherical aberration, high order aberrations. If you're working with surgeons that do CTAC surgery, our software now does connect to CorneaGen, so automatically our data will go right to CTAC to make your surgical planning software effective. Similarly, in the near future with STAR, the Evo Visian software is going to utilize for sizing of the ICL. Historically, there's been everything from calipers to UBM, but STAR is going to sanction that the most consistent method of sizing the Visian Evo ICL is going to be with the Pentacam horizontal white to white, and there's going to be a direct connection that you can download into their future software coming soon. Also, now you can get myopia management software with the Pentacam and also CSP Pro, not just the AXL, but the new HR. So thank you guys very much. I appreciate you hanging out. Here's my email address. If you have questions about a specific patient and want my opinion, send me the U12 file. If you need instructions on how to do that, simply email me and I'll send you the instructions. And this is my cell phone number. You can also use that. Another exciting thing that we have in the process with the FDA right now, and we're hoping to have approval again later this year, is a new Pentacam corneal OCT. And it's not just an OCT, but it's the highest resolution OCT available out there, 1.9 microns of axial resolution. It's going to help you see things in the cornea that we don't even have names for. It's that kind of resolution. So I'm very excited about that. And hopefully we'll have this in the US very shortly by the end of the year. So thank you very much. Michelle, do we have any questions?
We do, and I just wanted to say thank you so much, Dr. Tullo, for that great overview. We've had quite a few questions come through, so I am going to focus on just one or two here. And
We're going to go over a little bit, but that's okay. I don't mind at all. So we'll try to get through as many questions as you can
okay,
do.
brilliant. And I did just want to say that, just a reminder, if you have something you would like us to ask or follow up after the webinar, you can go ahead and submit that question and we can get back to you via email. And if you did miss part of the presentation, you don't need to worry. You will be sent a link to the recording within the next week. All right, so I'll go ahead and I will read off our first question. So, when a patient is not an ideal candidate for LASIK based off the Pentacam data, what are your next steps?
That's a great question. Some of it depends a little bit upon what is their prescription, if they're high myope or low myope, or even a hyperope for that matter, which I'm not a big fan of hyperopic corneal surgery. But my next step, if they're not a LASIK slash smile candidate, because I put those two in the same category, because both those procedures are pretty close to equally biomechanically destabilizing, I'll consider PRK. And especially if they're a low to moderate myope, I think PRK is a fantastic procedure, and it's less corneal destabilizing. So depending on how abnormal the cornea is and what age the patient is, PRK may be an option. If PRK is not an option, my next step is looking at an ICL, even a toric ICL if necessary. And then if that's not a possibility, is refractive lens exchange. Are they older patient? Is refractive lens exchange, especially if they're hyperope, refractive lens exchange may be the best solution. So there are other choices besides the typical go-to LASIK procedure, but I usually go by what the abnormality is. Is it a patient I think I likely will destabilize with any corneal surgery? And if it is, I'm then going to probably go more to either a ICL or a lens procedure.
All right, thank you. Now, this question was, do you monitor changes in corneal shape over time in post-refractive patients with the Pentacam? And you were showing that you were doing that using the Compare to display. But when you do that, what are some red flags for you? How often are you doing follow-up? What are some of your follow-up procedures and what indices are you looking at?
So I'm fortunate to have the Pentacam in my general clinic. So every patient that comes to my clinic gets a Pentacam on their routine annual exams, whether they've had refractive surgery or not. But by default, I'm getting a Pentacam every year after LASIK, and I tell patients before they even have LASIK or PRK. Or any corneal procedure that we're going to be monitoring them very closely, and I show them the Pentacam. I said, this is the image that you need to get taken, because if you leave my practice and move to somewhere else, I think it's very important that you get followed for the rest of your life with a Pentacam imaging. And maybe every year might be overkill, but I've never been disappointed by having too much data. So again, I think in other practices, I know I have friends in other places that will get a Pentacam every 3 years or every 5 years if they don't have it right in their clinic. But I like to feel very comfortable when I'm doing an annual exam after LASIK, looking at that scan and making sure that there's no destabilization. And if there is destabilization, then I can surveil that patient a little bit more closely, and monitor them, because cross-linking is very effective in post LASIK eyes. And I don't want to delay to the patient loses best corrected vision.
All right, thank you. Have you encountered patients who have had poor outcomes after surgery for whom you noticed key parameters or considerations that were overlooked preoperatively? And what most commonly are those parameters?
Wow. Well, yeah, I would like to say that I never have a patient with a poor outcome, but that certainly wouldn't be true. And especially early on in our early experiences with LASIK, we really didn't understand how important corneal analysis was, and we didn't have the tools to analyze the cornea back in the 90s. So we did unfortunately have a lot of patients who had bad outcomes. And as we analyzed those bad outcome patients, there were a couple of things that became statistically significant that we weren't aware of, and actually, frankly, didn't even look at preoperatively. And some of them obviously are the things we talked about tonight as far as abnormal tomography. But since we didn't have tomography and we only had topography, topography is wonderful, but it will pick up corneal abnormalities later in the course of the disease. So there were a lot of patients who had normal topography but abnormal tomography. But since we didn't have the tomography at the time, we didn't know that, and we did surgery, and they had poor outcomes. The other analysis we did retrospectively, looking at patients who didn't do well and developed post LASIK ectasia, was the best corrected vision asymmetry. And that's something we never looked at. I mean, I never looked at a patient who had 20/25 best corrected vision in one eye, 20/20 in the other, and thought much about that, or thought that that might be an indication that they should not have surgery. And once we learned that, now I'm much more careful on not only pushing my refractive candidates to the best corrected vision, but looking for those asymmetries and making sure I can explain them And if I can't explain them, I'm going to surveil them longer. So I will delay those patients and making sure that that asymmetry isn't increasing over time. And the younger they are, the more cautious I am. And the third aspect is that vertical coma. That wasn't something we looked at. In fact, we didn't even do aberrometry on our refractive patients in the 90s and early 2000s. Once we learned that coma was a sensitive finding, now I look at coma on every patient. If I see asymmetric coma or elevated coma in one or both eyes, that's also a finding that may delay surgery, may want me to surveil that patient a little bit longer. So good question.
All right, this question was just submitted. For post-LASIK patients, are you comparing the front elevation maps pre and post-LASIK for centration of ablation? Do you change the best fit sphere to be the same?
Yes.
Okay, brilliant. All right. I think that wraps up the questions for this evening. And I
Awesome.
just wanted to say thank you again to everyone who joined us and sent in questions. And of course, a big thank you to you, Dr. Tullo, for sharing your insights with us. Do you have any last thoughts for the audience tonight?
Yeah, only please reach out to me if you have any interesting cases or any questions about the Pentacam and its use, even outside of refractive surgery. I'm happy to help you navigate through that. That's what my job is as chief medical officer. So, thank you for coming tonight, and thank you again for all the great questions that you submitted. Have a great evening, everyone.
All right. This wraps up our webcast. On behalf of all of us at Oculus, have a great evening and thank you.